All right, perfect. Good morning, everyone, and welcome to Dr. Greg Rosen, all the way from the East Coast, where I guess it's 11 in the morning, and he's already had several meetings. Many of us, this may be the first for some of us. So, anyway, welcome. Dr. Greg Rosen is an assistant professor of medicine and epidemiology at Brown and a research scientist in the Division of General Internal Medicine at Rhode Island Hospital. He leads and contributes to implementation science research. Sorry, at the intersection of HIV treatment and prevention and substance use services globally. His research broadly harnesses um, health workforce capacity enhancement strategies and health system reconfigurations to optimize delivery of HIV and substance use services to impacted populations with attention to mobile and transient populations in sub-Saharan Africa and the United States. He earned his Master's of Science in Public Health and Doctorate of Philosophy in Social and Behavioral Interventions from the Department of International Health at Johns Hopkins. Prior to his appointment at Brown, he held positions at the CDC, the U.S. Agency for International Development, and Population Council. He has contributed to public health research and practice in over 20 countries and has consulted with several non-governmental and multilateral organizations, including Médecins Sans Frontières, the U.S. Children's Fund, and the Liz Glazer Pediatric AIDS Foundation. I could go on and on about Greg, but we also want him to get to his work. I had the privilege of working with Greg on a really interesting project that the implementation science cores were involved in, and I'm sure he's going to explain that more. But this is a really cool project, so I'm excited to hear him talk about it. And Greg, I'll keep an eye on the chat for you and try to only interrupt for clarifying questions. We'll save the talk for the end.
Perfect. That sounds great. And just wanted to confirm, I actually can't see anyone anymore because my PowerPoint has taken over all of my screens. So just want to make sure that you can hear and see the slide. You can hear me and see the slides.
Both.
Amazing. Fantastic. Well, thanks so much for that introduction, Jill. And it's wonderful and a privilege to be presenting to you all some emerging findings from what Jill was mentioning was our multi-site study on determinants of HIV status neutral approaches across the United States. And of course, beyond Jill and Dr. Miley Karras, who I'm sure many of you attending know well, this work was done in collaboration with a larger network of implementation science cores, which I'll be speaking about in a little bit. So I've spent, as Jill was mentioning, the last decade or so working primarily in HIV treatment and prevention services in sub-Saharan Africa. So the term status neutral care, the first time I heard it, was really interesting in the US context because historically in sub-Saharan Africa, all HIV services were status neutral in that treatment and prevention were always provided in lockstep with one another. So this, in a lot of ways, was a very large pivot for me as I was getting engaged in this work. And as I've been making this pivot more towards domestic HIV work, I found a lot of the implementation science challenges rather unique, but nevertheless extremely consequential, despite the availability of resources that our healthcare system has relative to other health systems where I've been working. So I'm going to start a little bit unconventionally with some acknowledgments. What I'm sharing today is going to be a culmination of years of partnership building and collaboration across this network called the Network of Implementation Scientists in HIV, lovingly what we call niche for short. And so when I'm using the term implementation science, I'm referring to the study of strategies that accelerate and optimize delivery, in other words, implementation of evidence-based intervention. So in this case, it would be HIV treatment like ART or a biomedical HIV prevention like PrEP or PEP. And so the lovely faces that you see on the right of the screen are folks across 6 NIH-funded Centers for AIDS Research and AIDS research centers who led the development and execution of this first multi-site study protocol called Niche 001. I wish we had a more clever acronym beyond just this is our first protocol, but in a lot of ways it sort of sets us up to sound like HPTN. And so, of course, this work would not be possible without the leadership of all these folks and the generous support of the NIH. So, I imagine some folks here are likely familiar with the Ending the HIV Epidemic or EHE initiative, but just to make sure we have all the bases covered, EHE is sort of the North Star in the US HIV epidemic response, with the ambitious goal of achieving a 90% reduction in new HIV infections by 2030. And so EHE has provided really phenomenal infrastructure to implementing partners, health departments, and academic institutions across the country to scale up evidence-based approaches to achieving really ambitious targets across four distinct pillars, which you see listed on the screen. So these pillars are diagnose, prevent, treat, and respond. So EHE priority jurisdictions include, in the map that you see here, 50 cities, counties, or municipalities where more than 50% of new HIV diagnoses are reported nationally. And this also includes seven different US states where there are significant rural HIV burdens that you see listed here in the somewhat green teal shading on the map. And so, one of these evidence based practices with growing adoption to meet these EHE goals is HIV status neutral care, which is sometimes referred to as whole person HIV service delivery. And so, status neutral is a service delivery paradigm whereby HIV treatment and prevention workflows, which historically have operated in silos, are brought together into parallel but synchronous workflows aiming to initiate and retain individuals in HIV services, depending on the outcome of their HIV test. And so, as you see on this somewhat cartoonish illustration, but I think it's a very impactful one nevertheless, the outcome of an HIV test on the left determines which service delivery workflow individuals will enter. And so status neutral approaches are gaining traction, so much so that the CDC has issued guidelines on best practices for HIV service delivery through this status neutral paradigm. So this has been embraced nationally as both an evidence-based practice as well as a public health priority. But I think it goes without saying that any adaptation to a clinical workflow in the US healthcare context is going to be a complex endeavor that requires sustained resources, personnel, and leadership commitments for equitable implementation. And I would say that status neutral delivery is no exception to this. In a review of 34 EHE jurisdictional plans that were led by the CDC that you see listed here, there were consistent barriers to HIV prevention and care delivery that emerged from this review. And I'll direct folks' attention specifically to the eminence of social and structural determinants of health, like insurance coverage, which undoubtedly will constrain the feasibility and implementability of status neutral approaches in various contexts. And so furthermore, as part of this network called Niche, we conducted a survey of 40 HIV clinics across 6 different EHE priority jurisdictions in the US. And what we found was that while status neutral delivery is becoming increasingly commonplace, implementation is really geographically inconsistent, meaning that there's places where people live, work, and play determine the type of clinical experience that they might have with HIV service providers, whether it's for treatment or prevention. So the bar chart that you see here listed on the right shows the proportion of Ryan White funded clinics that we surveyed that were implementing a status neutral approach or currently not implementing. And you can see that geographically, there was quite a difference in spread in terms of clinics reporting whether or not they were implementing status neutral approaches. And so all of these implementation constraints and inequities really provided the impetus for our study protocol, which centered implementation science frameworks to document determinants of several evidence-based practices related to HIV service delivery, and this included status neutral as well. And our protocol was structured across 3 sequential mixed method study aims that you see listed here. But the focus of my presentation today will be the second aim of the study, which used focus group discussions with embedded participatory mapping activities to identify barriers, facilitators, and strategies to enhance adoption and sustained implementation of status neutral approaches. And so we worked across 6 different study sites that you see listed here: Alabama, Baltimore, Chicago, Dallas, Los Angeles, and of course, last but not least, San Diego. And we purposefully selected these sites to be representative of the geopolitical urbanicity and implementation climate of the HIV response nationally. So to convene virtual focus group discussions with clinics that were both implementing as well as not implementing status neutral approaches, we compiled a line list, I should say, of healthcare establishments across these 6 jurisdictions that were receiving funding from the Ryan White HIV/AIDS program, what I'll just call Ryan White for short moving forward, to deliver HIV care. And clinics that participated in this previous survey I had described were approached to nominate various frontline HIV service providers to participate in virtual focus group discussions. So one of the advantages of, and I should say maybe unique attributes of this multi-site study, is that because the study teams were scattered across the country and participants were also scattered across the country, we really leveraged and leaned on virtual platforms to be able to convene different participants at convenient times and make this possible to do. And so we sought to conduct 1 to 2 focus group discussions across each of these jurisdictions. And we intentionally sampled personnel other than licensed clinicians. So think of folks like case managers, patient navigators, outreach specialists, to elicit perspectives on various components of the status neutral workflow. And then we also leveraged the networks and capital of our exceptional protocol chairs and advisors to identify clinics who otherwise might not have been sampled because of their non-participation in earlier components of our study. So we moderated 8 focus group discussions overall, which were transcribed using AI-assisted transcription services that were native to our teleconferencing interface. And our focus group centered discussions around the illustrative, what you see here is an illustrated status neutral workflow. And so this workflow we created internally, and it was derived from existing manuals of operating procedures and other publicly available information. And we really tapped an expert student illustrator, which I hope is reflected in the visualization that you see, to construct this workflow. So participants could quickly, during these focus groups, digest and make quick comparisons with the workflows that were present in their own clinics. So we used what are called participatory matching approaches, where throughout these discussions, we elicited perspectives around the sequence and actors involved in various stages of implementing this workflow. We also, as part of these focus groups, used what's called the Consolidated Framework for Implementation Research, which I'm sure many folks have heard of, also CFIR for short, to really explore different determinants of implementation. And so what's nice and helpful about a framework like CFIR is that it helps identify both enabling forces that we call facilitators, as well as constraining forces that we call barriers to implementation of evidence-based practices like status neutral. And CFIR is a very large framework, as I think a lot of folks can see here. So we really honed our discussions around what are called determinants that are nested at the inner and outer settings. And so the inner settings in this case would be institutional determinants that exist within a healthcare facility or a clinic, and the outer setting would be more the healthcare system level determinants, as well as the interactions with policy. And so I'll quickly talk about how we analyzed data that emanated from our study. And so it really revolved around using a team-based thematic analysis approach. So we began with same-day data collection debriefs with the study team and using semi-structured field notes from the focus group discussions to identify emerging themes and salient findings. Uh, we basically then had team members migrate these emerging themes from the transcripts and the field notes to a somewhat unstructured data collection, data abstraction matrix that you see presented here. Um, this matrix was really organized around those domains that I had showed you before from the Consolidated Framework for Implementation Research. So what we did next is then we reconfigured insights from that were populated as part of this abstraction template into a much more structured matrix that was organized around the 70 plus different constructs that are included in CIFAR. So you can imagine this was very, very detailed, a very detailed task. And then over the course of a 3-day in-person workshop, we synthesized and used different data display approaches like you see here to illustrate the relative salience or importance of different implementation determinants that we identified from our previous analyses. And we reorganized them using techniques like you see visualized here, called heat maps, which essentially help us identify the relative importance of specific constructs, which essentially in this case were determinants of implementation. And then lastly, we held ongoing discussions with the investigative team. We did some member checking sessions with study affiliated clinicians and revisited the data throughout the process to help us solidify and crystallize some of our conclusions. So just to describe the profile of folks who participated, we had 56 different service providers representing 20 clinical organizations across these 6 jurisdictions that participated in a focus group. And the spread of the cadres they represented are shown here, with nearly 60% identifying as program coordinators, navigators, case managers, and social workers. So folks that historically do not have prescribing authority. So what you see here is a heat map that illustrates the presence of implementation determinants across our study, and they're stratified, as you see in the columns, by different sites. So the rows that you see illustrated as part of this heat maps map onto different constructs in the inner and outer setting from CIFAR, excuse me. So as a quick orientation to this heat map, which I don't expect anyone to read line by line, I'll sort of walk us through some of the takeaways. The orange shading that you see represents a barrier, and the blue shading represents a facilitator. So the presence of both blue and orange in a single jurisdiction indicates that a particular construct was cited as both a barrier and a facilitator in discrete or different organizations that were present in a focus group. So rather than going through this table line by line, which I'm sure no one here wants me to do, and it would put everyone to sleep, I would like to just share one take-home message from this table. And that take-home message is that the barriers to status neutral implementation really heavily clustered in the outer setting, and facilitating factors were concentrated heavily in the inner setting. So honing in on some of these more salient barriers and facilitators, we see that contractual restrictions that inhibited Ryan White CARE Act funding to be used for HIV prevention services, coupled with insurance authorization requirements for appointment scheduling, were cited as among the more salient constraints to implementing status neutral approaches across jurisdictions. Within the inner setting, so at more the clinic or organizational level, we see that insurance and policy restrictions were attributed to sustained siloing of HIV care and prevention services, making it ever more difficult to deliver a status neutral care approach, even in the presence of strong commitments from clinic leadership and perceived demand from clients and patients. Further, even when clinics wanted to prioritize a status neutral approach, this prioritization sometimes conflicted with perceived demands from patients for integrated services. So, for example, providers relayed concerns from persons living with and without HIV that these patient populations might not want to have shared waiting rooms or concurrent appointment intervals with each other. demonstrating how individual client preferences may not always align with evidence-based practice. But importantly, we did observe numerous innovations facilitating status neutral implementation. This included things like the development of implementation blueprints that articulated roles within the service workflow, as well as dispensing shorter duration prescriptions for HIV medications and prophylaxis, so clients could receive services without delays attributed to appointment scheduling challenges or prolonged insurance review pipelines. So we also, as part of this work, documented numerous strategies that clinics adopted to make status neutral implementation a reality in their contexts. So within the inner setting or at the clinic level, this included procedures and policies that enabled the workforce and clinics to be more responsive to client needs. So for example, offering telehealth appointments to initiate HIV treatment or PrEP. This also included cross-training of staff to fill multiple roles or complete complementary services within the status neutral workflow, as well as identifying ways to support prevention services within the restrictive parameters of HIV treatment contracts. So, for example, having navigators that were primarily assigned to HIV treatment services also support PrEP initiation and linkage services. We also identified some revolutionary strategies at the policy or systems level that accelerated implementation of status neutral approaches. And so these included formalized partnerships between clinical organizations. So thinking partnerships between emergency departments and primary care services. So continuity of service delivery was possible after clients left one setting and picked up services in another. These also included policies like in California, which allow for some non-clinical actors to dispense medications to clients who already have active prescriptions, meaning that you don't necessarily need to have a prescriber on site to dispense medication. And this also included financing related arrangements like what we observe in Baltimore and Chicago from external actors like the health department, which covered financing gaps attributed to restrictive parameters like Ryan White HIV contracts. So in Chicago and Baltimore, this meant that the health departments really stepped in with their own funding to subsidize entities to provide prevention services that otherwise might not have been possible within their Ryan White contracts. And so, as I mentioned, as part of the participatory mapping activities,
Sorry, Greg, there was a clarification. Just cute, go back, slide before, slide, sorry. Is this the slide, Paloma? Ah,
Yes.
Paloma was asking, right, when it's blank, so when it's white.
Yes, thank you for that clarification or question, Paloma. That means that it was missing, so it was not present. Like a specific construct was not present.
So that would, I guess, depending on what it is, it could be good, it could be bad.
Exactly. Like it just
Okay.
didn't emerge in our data. So that means that it was neither, it was not, it was not, we're not sure if it's a barrier or a facilitator.
Thanks.
Yes, of course. Thank you for the clarification. Um, So we really sought as part of the participatory mapping activity to identify attributes or features of the status neutral workflow that were distinct across clinical organizations. And what we found is that there really were a diverse set and heterogeneity of approaches that really are possible in this space. And so these features included the timing of patient insurance review in the workflow, whether action within the work activities or services within the workflow were implemented in sequence or concurrently, whether clinicians or non-clinical actors like case managers and navigators were charged with delivering services that you see illustrated in the workflow. And lastly, whether HIV testing, which we sometimes call the on-ramp for status neutral care, occurred within or externally to the organizations where HIV services would be delivered. So I'm going to now talk through these four difference-making attributes in a little bit more detail. And so what we see illustrated here is that we found that the timing of insurance assessments really varied across clinical or different clinical organizations. And this was what we think primarily attributed to available implementation resources or the responsiveness to the dynamic nature of client needs. So in some clinics, there was insufficient staff, and so it was more strategic in some cases to complete an insurance review earlier in the clinical encounter to effectively triage clients based on their insurance needs. However, in other clinics, there was much greater flexibility over the timing of insurance assessments, and even in some cases, conducting insurance assessments more than once for clients. And this accommodated changing insurance needs for specific clients who may not actually be able to complete all the steps and sequences of activities that are illustrated in this workflow in a single clinical encounter. So, in other words, some of these clients may require multiple clinical visits before they are effectively linked to either HIV prevention services or treatment services. And this kind of staggered insurance assessment review really allows for the kind of flexibility that's needed to accompany clients throughout this pathway. We also found that clinics were distinguished by the magnitude of structure in these workflows. So while some clinics described a process of administering specific services and then handing clients off to other personnel or departments for other services, this was oftentimes an artifact of larger bureaucratized entities and organizations that could explore ways to reduce workloads across their personnel. We also saw that other clinics completed these different activities in the workflow simultaneously. So rather than having them occur in sequence, these different sort of pre-linkage activities occurred concurrently. And this actually was a strategy that reduced the number of staff and personnel that clients would see during a clinical encounter. So for some clinics, this latter approach prevented bottlenecks in the workflow if there was that sequence of activities that was required, and it imbued an accompaniment-oriented ethos into each clinical encounter. So it wouldn't necessarily involve several different actors seeing an individual for different things. It would mean that maybe one or two folks at most were engaging and cycling through the clinic room to administer these activities. And so we also saw that clinics were distinguished by the types of providers that really were engaged in this workflow. So for some smaller clinics, which tended to have fewer staff, these were typically characterized by clinician-dominated service workflows. And what we mean by that is that oftentimes it was prescribers who were providing or delivering most of the services that you see illustrated along this pathway. And in some cases, they might have been supported by another non-prescribing staff member. Uh, in other clinics, by comparison, these were characterized by more decentralized workflows. And what that means is that many non-prescribing staff members, like case managers, social workers, navigators, were implementing different components of this workflow. And this approach was frequently a response by organizations to facilitate cross-training within their workforces. This would allow it in, at least in the perception of folks who participated in our focus groups, this type of cross-training meant that these folks could fill different roles and successfully perform different activities when circumstances required. So it gave greater agility and flexibility perceptively to this workforce. And then lastly, clinics were also distinguished by the location or setting of HIV testing, with many clinics in the study sample describing having to rely on external partnerships. So, for example, health department clinics, emergency rooms, or other community-based organizations to refer individuals to their services rather than having HIV testing occur in-house or on-site. Um, the reason is that oftentimes funding regulations in some cases prohibited leveraging existing funds to procure HIV tests for initial screening encounters with clients, which meant that they might not have been able to offer, for instance, HIV testing outreach which is how folks in many, especially urban areas, would sort of get into a prevention or treatment workflow. So maybe to close us out for today, what we saw was a lot of different but consistent barriers to status neutral implementation across this very geographically diverse sample of clinics. Many of these barriers really clustered at the intersetting. And as a result, the burden of innovative strategies to enhance implementation of these status neutral models really fell onto the clinics themselves, which tended to operate in resource constrained environments. And many of these implementation strategies also involved adaptations to the clinic workflow or workforce itself. Further, while enabling policies and financing environments might be necessary for effective status neutral implementation, policy and financing alone was insufficient to make status neutral HIV care a reality. We also observed asymmetries between institutional and organizational prioritization of status neutral care, and perceived patient preferences for how they want HIV services delivered to them. This is also going to be a focus of forthcoming research and publication that's part of our network, where we've done interviews with folks that have recently initiated ART for HIV treatment or PrEP, for HIV prevention within the status neutral paradigm, to understand what their perspectives about status neutral care and these workflows look like from their perspective, which is admittedly a limitation of the work I'm sharing with you today, is that we only elicited perspectives from folks that were engaged in the clinical workforce, whether as prescribers or non-prescribers. And lastly, while we didn't identify a singular recipe, so to speak, for effective status neutral implementation, the menu of implementation strategies to accelerate adoption and sustained implementation of status neutral um, does not really involve what I would consider substantial reimagination of the clinic workflow. But rather, what it might involve is materializing connections between disparate components of the workflow to function more cohesively as an effective whole. However, it's not really possible to spend time and effort doing this work without access to supplemental financial and material resources. So it's a lot, I'm sure, as everyone here can attest to and agree with. It's this kind of labor, while it's possible to sort of reconfigure a workflow in a specific clinic, oftentimes it requires additional resources and time to make that happen. And so really what and I think others would advocate for in this space, is making sure that there are an appropriate amount of material resources and finances that are devoted to buying folks' time and energy to think through these creative reconfigurations. So as I noted at the start of this presentation, Niche is a powerful multi-site collaboration between 8 different academic partners who are committed to advancing the goals of the EHE initiative through implementation science. And this work really would not be possible without the time and contributions of them, as well as our focus group discussants who work tirelessly on the front lines of the HIV response and merit a lot more than I think the recognition and acknowledgement I can just give them here. So I wanted to take a moment to express our gratitude to all of our research partners and study participants. Many of them are featured here on the slide. It's really been a pleasure presenting findings to you all, and I look forward to our continued dialogue and conversation right now. But in the interim, please don't hesitate to reach out to me if you would like to continue this dialogue offline. There's obviously some publications that are in the process of moving through the peer-reviewed pipeline. I'll be excited to share some of that work. We have other existing work that our network has published more formatively not necessarily the work that I presented here today. So in a lot of cases, you're getting a sneak peek to forthcoming work that we'll have hopefully in press very soon. But wanted to thank you all again for the invitation to present here today and share some of our findings and insights. And I look forward again to your questions and comments, as well as the dialogue that we will about to have. Thank you again for your time.
Greg, thank you so much. There was one comment just about your amazing animations in your in the
Susan says
really,
plus one to that. I think she knows.
No, I've got it. That's my hand. I could raise it, but I don't like.
Susan, go
Tired
ahead.
of the little hand on Zoom. I just wanted to ask, you may have said this sort of, but sort of systematically, if you could break down the outer barriers, constraints to being more focused on the program, meaning Ryan White,
Mhm.
or the institution, meaning bureaucracy,
Right.
cost.
Yeah, that's a great point, Susan. So I think it was actually it's an interaction between the two, because part
Okay.
of it is that there are existing funding regulations, as I mentioned, and I'm sure a lot of folks here that are, working in Ryan White programs or have or are doing HIV
Yeah.
care know that those exist. A
Uh-huh.
lot of jurisdictions where these clinics are operating, recognizing what those barriers are, have availed different structures. So I was mentioning Chicago and Baltimore, for example, where the health departments have offered supplemental funding to support organizations to do, for instance, HIV prevention that is not accommodated by Ryan White contracts. At the same time, so this is where I think a lot of this work gets very complicated, is that there are, in addition to these existing policy, finance, and insurance regulations at the outer setting, there are other challenges that exist, I would argue, somewhat independently of those outer setting constraints at the institutional level. So, for example, staffing shortages, which, I
Yeah.
always, as someone that works in public health and has done this for like a decade now, we can attribute anything to something very structural. So I don't want that to be the cop out. I also
Yeah.
think that there are institutional arrangements and policies that exist pseudo independently of our healthcare system and financing and policy environments that make it more difficult to do this work at times. So, for example, just reflecting on my own, I'm not going to name any names for the sake of
Yeah.
privacy, but reflecting on my own recent experience seeking care at a large hospital entity. Being told that the person at the clinic can actually schedule me for my next appointment, that, for instance, I have to go to a scheduling line to do that appointment. So in some cases, the bureaucratization
Yeah.
of the workforce does provide some benefits, but at the same time, for maybe this, if we think myopically about status neutral HIV care, there are both challenges to the workforce, so to the implementers, as well as the
Mhm.
patients or clients, as a result of some of these arrangements that may actually be in the spirit of efficiency from an institution's perspective. Um, I don't know if that answered your question. I feel like I just like
Yeah.
rambled a bit
No.
about everything that
No,
I know
very
you
helpful.
know very intimately from your work.
Yeah. Thank you.
I was just gonna brag very quickly about San Diego County. I don't know if Greg, you recall this, but what Greg said, and we'd have to go back to the early slides. We don't have to, but in the first phase of this study, all the Ryan White clinics, the managers or directors were emailed a survey to complete. And I think we were the only one that had 100% participation from our Ryan White clinics. Now, we're much smaller than Los Angeles County, so it was a little bit easier, but it was really nice to see that all the Ryan White clinics participated, which meant for this round, anyone who participated in the focus groups were people who had responded to the survey. Whereas, Greg, there were people who were included who didn't respond to the survey. And I was wondering if you could, I don't know if the data reflects on any of that, of who participated. And I think we had different reasons for why people participated or not. It didn't necessarily mean that you were someone who did or did not practice status neutral,
Hmm.
have status neutral practices. But I'm wondering if there was any difference that you could ascertain from participators and non-participators in that first round.
Yes. So I would say, and I really wish I had put a QR code up for the publication that Joyce Jones from the network led, where they had looked actually very closely at sort of comparing folks who participated to didn't. From the status neutral perspective, there weren't a lot of differences. And interestingly, if memory serves me correct, for our focus groups, the majority of folks that were initially non-participators in our survey actually were status neutral implementing clinics. So I think one of the things that we learned as part of trying to reach out to these clinics that did not initially participate is that obviously the Ryan White program is dynamic. And so in some cases, because this had occurred over a 2-year period, we actually saw some new clinics emerge into the Ryan White program because they were newly funded to deliver services through Ryan White. So I'm thinking specifically that was the case in Dallas, where we actually had more non-participating clinics um, that were represented in our focus groups than folks that had previously done this survey. And that was simply an artifact of expanded Ryan White Care Act funding in that county. Um, I think also, Jill, it's kind of hard to say if there's really any differences, because I think that a lot of the differences that we really observe are, one, I think as folks here imagine, are geographic in nature. So county, municipal, and state policies really distinguish how status neutral is implemented. Of course, California, and I'm not just saying that because I'm on a call with a bunch of Californians, but California has really like led the charge in making PrEP a lot easier to implement for clinics, with some policies, or even make status neutral more feasible for clinics to do. As I was talking about with some of these dispensing regulations that are really unique to the environment or to the policy environment. Chicago is another jurisdiction that comes to mind where there's a lot of innovations in this space, and other jurisdictions I think are newer adopters, if you will, to the status neutral paradigm, and have really had to do a lot of proactive education of their legislators to make their lives easier.
That's very helpful. Nettie, would you like to share some of what you wrote? I don't know if you
No,
can.
because I told Tari I would be more positive. Sorry. So anyway, that was a great talk. Thank you so much. We're working very hard in status neutral and integrating all the things. And I just was pointing out, not to be a bummer, but just to be realistic, that, especially that first bar where you showed those, what are the factors, and insurance barriers were kind of at the bottom with this big long red bar. To me, every year our health system gets more and more complicated, and we've tried to protect our patients in our programs, be they, in a status neutral way, protect them from the tidal wave of the healthcare system. But it gets harder and harder because insurances are complicated, Medi-Cal changes, your coverage changes, you re-enroll here, you re-enroll there. And so I feel often like in our field, we're having to fight against this other tide, which is sort of an elephant in the room. And even if we implement status neutral perfectly, that sort of insurance healthcare system part of the equation that our patients now have to live in is getting harder and harder and more complicated. And for many of our patients, they throw up their hands and say, I don't want to engage in this. And that's probably I think that's my biggest challenge as a program director, is to try to protect our patients from that.
That is such a fantastic point, and I appreciate the realism, even if, a pessimistic outlook. And I agree with you that it does feel like there's so many things we identify in this work, and not just the work I've shared here today, but also more broadly in implementation science and health research, where it just feels a little bit out of our control. I've been doing, and we've had broader conversations about this in our own network, of how do we come up with a science of like insurance related implementation strategies, because I feel like that is also one thing that I think really could benefit the field, is thinking through, for these policy related barriers, And in some cases, it's not policy because it's sort of controlled by corporations. It's sort of because of the way our healthcare system and our laws broadly exist in the country. This is like the system that we have as a result of that. So how do we innovate in a space where the traditional paradigm of clinics have a certain level of control, but then there's local policy, then state policy, then federal policy. Now we add in this dimension of capitalism and we add in this dimension of corporations. And how do we engage in implementation science in a way that makes not just this less of a barrier for patients, but also for the providers that have to be the ones, really managing these really challenging circumstances, and exhausting circumstances, frankly. So reaffirming that I also have been thinking a lot about this and really advocate for, folks in sort of the implementation science space to be able to think about engaging in strategies around insurance. I don't have a good solution. I think, yeah, maybe. I mean, I think if there were a good solution, it would have already materialized.
So Nettie's at San Ysidro Health. Excuse me. I think there's some other folks on here from other FQHCs and other health systems. I think we try to do this, but it's just very hard within our own silos is to try to work together. I'm thinking about like particular patients. Okay, well, if this isn't working here for them with this insurance, maybe it would work at my colleagues, but it's so much it's so much easier said than done to just be like, all right, we'll just move this patient over to this, this place, especially if they've been there for a long time. I don't know. I'm just thinking things like that where I think we all like the idea of a very close network of Ryan White clinics that work together. But in reality, I think that's very difficult. And I'm not, in charge of Ryan White programs, but that's just my sense of things. So yeah.
And I also saw Susan has her hand raised, so
Yeah.
I'll get to Susan in one second. But
Yeah.
to that point, Jill, I think that, something else we also sort of observed as part of this work that we talk a lot about in the network is learning collaboratives and just how much knowledge sharing and networking there can be between entities that receive funding that in some cases are competitors, but how can we sort of bring everyone to the table to sort of co-innovate and like be more agile. And so instead of operating as siloed health entities, is how do we like create a sort of parallel seamless system where like there aren't cracks for both providers and patients. And I think something, Dallas County, for example, was another place where there's such a small number of providers where they do this really effectively because in the county, there's maybe 4 or 5 different places where folks can go, and that's really only where they can go. Something that we've learned from them, which is really interesting, is that as part of EHE money, there's a lot of people from other neighboring jurisdictions that have to go into like Dallas or Tarrant County for their care. And that's maybe also the case in San Diego County. And one of the challenges is sort of like, how do we do management for folks that don't live close to, where they're getting their care and have to sort of go really far out of their way to get care. Obviously, telehealth is a great innovation in this space, but there's a lot of folks that can engage in telehealth for a lot of different reasons, whether it's like computer literacy, network literacy, or just inaccessibility or unavailability of that service. And so it kind of feels like a jigsaw puzzle of problems, and it's figuring out how to get as many of them solved with the limited resources available. But I will say that it feels like networking between clinics does go a really long way. At least at minimum to build rapport between organizations. So handoffs could be done a little more easily rather than to just some random phone number for an administrator. Susan, sorry, I know your hand was also raised.
No worries. The jigsaw puzzle's getting harder every month. But I was just curious if there was enough long-acting PrEP to assess its impact, across Ryan White providers in terms of status neutral care Harder, easier, totally varied.
So I would say at the time that we were collecting the data, CAB-LA was really just starting to gain some traction. So we definitely heard providers talk about it as like, we have patients that are on CAB-LA. They haven't, I think the biggest thing that we've learned is that a lot of providers that where their clinics were offering CAB-LA and had patients, they were managing on long-acting formulations, whether it was treatment or prevention. We're really advocating for like, we actually need to have a distinct workflow for this compared to daily oral medications or episodic medication. The reason being is that the prescribing regulations around CAB are very different. The kinds of folks that can administer it, the frequency of visits, and like what folks' needs might be look very different. And so I think if there's anything that we learned about it is that a lot of folks say we actually need a completely distinct workflow that doesn't look like, I know, more work, right?
Do the whole study again.
But yes, that's really what we learned. Unfortunately, not a whole lot else about long acting since.
Okay, thank you.
Does anyone else have any comments or questions for Greg? I'm hoping I didn't miss anything. Sorry. I don't think I did. I will also just say this group of individuals is one of the most productive as far as publications go. I swear every 4 days there's someone else saying either this was accepted or this is a poster or a paper. I'm like, my head is spinning half the time. I mean, there are a lot of really unbelievable people involved in this work. So not me who's doing any of it. I'm just yeah, so blown away by it. And I do hope it has the effect that we want it to have as far as implications for implementation practices and improvements in the way we deliver this healthcare. I guess, Greg, I turn it over to you, back to you for the last word. What are you hoping from all of this work and all of the iterations of it, the different phases? I don't even know what, I think y'all like in a future phase now. What are you hoping to do with all of the work?
Yeah, it's a great question, Jill. And I feel like I have to revisit it a lot just because the needs and the landscape are changing what feels like a lot. Of course, a lot of this work was completed before January 20th of this year when a lot of things in our policy environment began to change. And I think something that's been very valuable about this work, which I'm hoping is sort of feeds into practice, is like what we've learned is really, whether it's San Diego County, whether it's Dallas, whether it's Baltimore, there's people that are innovating and doing sort of bringing things to practice every day that other jurisdictions may not be aware of. And I think helping to facilitate that crosstalk is something I've personally found very powerful, is that when we're so busy and overburdened with everything else we have to do, sometimes it makes sense to just operate in our silos. And by silo in this case, I really just mean like our jurisdiction. And I think there's a lot of cross-pollination of lessons that could be very valuable here. And so, as an example of that, in Chicago, there was the health department mandated status neutral care. And so everyone was incentivized to do it because there was a mandate for it. That's not to say that something like that would work in Alabama as an example, but really generating this line list that helps sort of identify what different jurisdictions are doing to make this possible, I think is really useful. And that's a great next step. I also think we need to critically be thinking, as I mentioned before, to what Nettie was saying. I think we need to really think critically about how do we now move beyond band-aids that clinics are really implementing, that we call implementation strategies, and really have strategies that tackle these structural issues. So how do we work with the existing insurance landscape to make this a possibility? So that's kind of where my head is going, and where I really would like to see this work go.
That's very helpful and very interesting to hear as well. So thanks so much, Greg.
Yes, thank you all.
Thanks
Yeah,
so
and
much.
thanks so much for joining us, although I realize it was later for you, not an early morning.
Yes,
But
I
we
know
still
it was a
appreciate it.
luxury. It's a luxury to do this at 11 a.m. on a Friday
So-
rather than 8 a.m. For you all, you probably are just like rising and having your first hit of caffeine.
For some people, yes. Anyway, thanks so much, Greg, and thanks everyone for joining. We will see you next week. Bye-bye.
Thank you all. Take care.